there is three major reasons why people are getting sicker and sicker in this country. And the three reasons is that they're hormone deficient is one. The second is the fact that they are insulin insensitive, which creates a general inflammation in the body. And the third is there is a energy deficiency in the body entirely.
Welcome back to Bathroom Diaries with me, your host, Dr. Sophia Din, the podcast where we talk honestly about aging, hormones, beauty, and the science of living well. Today, I'm joined again by Dr. Rob Frankel for another episode in our Peptide Playbook Series. Every time Dr. Frankel comes on, the conversation gets deeper. And today we're tackling one of the most misunderstood topics in medicine: hormones and metabolic health. Why are people getting sicker despite having more medications than ever before? According to Dr. Frankel, three major forces are driving modern disease: hormone deficiency, insulin resistance, and energy deficiency at the cellular level. In this episode, we unpack the real story behind testosterone, menopause, andropause, statins, cholesterol, and metabolic inflammation, and why many patients are being treated without ever addressing the true biological foundations of health. If you've ever wondered whether declining hormones are affecting your energy, weight, mood, or long term health, this conversation will open your eyes. Let's dive in. Morning, good afternoon, I would say now. Dr. Frankel, thank you once again for coming in on Peptide Playbook Series. We just can't seem to get enough of you. We can talk to you for hours and then we'll come back the next day and again have questions. So thank you for coming back on this. The understanding about hormone replacement therapy is continuing to evolve. And one of the things that I took away from yesterday was that not only women were actively misguided as to how to deal with their menopause, but also similarly, men were not even guided that there is a pause that they're gonna face and how to not only supplement themselves, but also the doctors were not trained based upon this study that you were mentioning. So I will give the mic over to you to start us out with what happened, and then we go move to testosterone therapy, and then we move to what are the things people have to be careful about as they treat themselves or seek treatments.
Well, it was very, very nice to be back with you, Dr. Den, as always. I am on the road, but as soon as you said that you were interested in talking again, I found a way to set up a camera, and here I am with you. So it's exciting to be here, and it's a great topic. And I think that together between you and I, we are going to help revolutionize the new era of medicine. So I'm happy to be here and happy to be part of this experience. So thanks again for letting me have the floor. So yeah, I mean, there's a lot of information about male hormone replacement, and I did start my career as far as anti-aging medicine because of the fact that I was, struggling myself about 20 years ago, and a doctor who was working with anti-aging medicine, took me aside in the emergency room and said, he has a clinic. He wanted to, talk to me and try to help me out, and he did, and he really changed my life. And I said to him, why are not more doctors, doing this and giving their patients the experience that you gave me? And what we realized, and I think that I spoke to you yesterday about this, that when we were in medical school, the amount of time that they talked about hormone replacement, hormones in general, was, like you said, about as much as they talked about nutrition, which is almost nothing. So I think that a lot of the field has been misled to thinking that this is not only important for quality of life, but actually the overall health of patients are, greatly diminished by the fact that they are not being replaced with their hormones. And I think that it's a great topic, and we'll start wherever you want to start, Dr. Dan.
Yeah, we can start today because you're also the host of Modern Man, and I'm so grateful for you to coming on my Bathroom Diaries. But like, I think because we basically talk about the same thing, we can. I usually like to address a lot of issues for women because most of my clientele is female. So, but I do have some male clients, and for their for them, I do want to start with the understanding of testosterone, because other than estrogen and progesterone, which are like some of the most misunderstood hormones, testosterone is a very misunderstood hormone. And I actually made a slide with the guide that you sent me, the chemical structure. So you want to like guide us through testosterone
Sure.
and what happens that it goes down, and what are the things that we are doing incorrectly?
Okay, sure. Yeah. So this is a very interesting slide that, I mean, it's a very simple slide. I found this last night to kind of intimate exactly what happens with testosterone and how it actually interacts with the estrogen. So one thing that we talked about yesterday, which we're going to talk about again, is that as men start to age, what happens to a lot of them is that the testosterone goes down. And regardless of whether their estrogen goes up or stays the same, the hormone of estrogen becomes a more prominent figure in their life. And this is not a great thing because for men, it helps them store fat. It actually decreases their energy, it decreases their sense of well-being. And estrogen has a lot to do with the fact that our bodies are changing. So one of the things that you hear a lot on like TV, radio ads is that you could take this product and you can produce more testosterone for men. And so this is one of the things that does drive me a little bit crazy because one of the major products, and you asked me about this last night or yesterday, and you could see the DHEA. Do you see that on the screen? That DHEA, right?
Yes.
So what happens with DHEA now is that so when you see DHEA, it's sold in health food stores, it's sold, over the counter, it's sold as this miracle drug, or miracle thing that's going to help you produce more testosterone. Many men buy this, and women too. And so what happens is that you could see the pathway. It goes from it goes into the androsterone, and then you could see that it has two pathways. It can lead. It could either go to estrogen to produce estrone, or it could produce testosterone. Now, if you're lucky, all the DHEA that you're taking is going to produce only testosterone, but the likelihood of that happening is probably not great. And so this is the problem when you are talking about products that you're buying that you want to boost your testosterone without actually doing it with a licensed practitioner who understands this stuff, because of the fact that what will happen is that what I said earlier is that most men start to become estrogen starts to become a dominant force in their body. And when they take these products, a lot of times what's going to happen is that they're going to become even more estrogen dominant because the DHEA, instead of producing more testosterone, will actually produce more estrogen. So it's very important that when you do hormone replacement, or you feel like you're fatigued, you feel like your muscles are not as strong as they once were, you feel like you can't gain muscle, you feel like you're getting heavy around the midsection, you feel like you have brain fog, because testosterone for men is its major hormone. Then you realize that you need something, and you go to a health food store and buy DHEA, and a lot of times it's not going to be the best thing for you. It's actually going to be counterproductive as opposed to helpful. So that was the first kind of thing that, to talk about, like how important it is to get evaluated properly and to be treated properly, to boost your testosterone and not have other things, as well.
When
Go
I
ahead.
look at this chart, it is very telling, because you can see the pathway from cholesterol and how cholesterol is being converted into progesterone, and then eventually to, it's all interrelated, and then how it comes to become testosterone, and the same hormone that is splitting the DHEA into estrogen is also the hormone that is splitting the testosterone into estradiol. So
Right.
I get it. And one of the comments that we had made yesterday, it kind of like stands true with this diagram of yours, that with menopause, women tend to become men, and how men can start developing characteristics of women with the pause.
Right. Right. And so that's a big part of it. And so, for men, a lot of times they will take testosterone, on their own. But again, what they don't understand, and maybe don't understand about the physiology of it, is that when you take exogenous testosterone, you could see with this pathway how easily it starts to become. It can be, when you're putting too much in, it starts to become estrogen. And so estrogen, of course, what it does is it actually blocks the receptors of testosterone. So end up needing more and more testosterone to feel the way that you did originally. But on top of it, the effects of estrogen, which in a lot of ways are counterproductive, they produce more, stored fat. They produce, more. Lactorrhea, as well as just in general, they start to decrease the positive effects of testosterone for men. And so it's important to realize that when, we do it as practitioners, we'll usually give testosterone, but also an estrogen blocker at the same time to men, because what we want to do is we want to isolate the testosterone and keep it at the lowest level that we need to get them to where we need to get them without the counteractive effects of estrogen for men. So, I mean, it's super important that when you do testosterone replacement, you'd have to do it, properly with a practitioner who understands this, not only doctors who learn it from drug reps, which we got into last night as well. So,
So, what estrogen blocker do you recommend?
an anastrozole or Arimidex is one of the ones I use, commonly. You only have to take the pill once a week, usually. I mean, there are some people who are more prone to develop estrogen. They might have to take more. There are natural products. There's something called DIM, which is a natural product that helps to kind of block estrogen production as well. So there are a few things, that you can take. But I mean, it's important to understand that, because of the fact that, understanding the chemistry in the body is paramount to be able to help patients, and not just giving them something. And you make a good point about cholesterol too. One of the things that we found is that more people who are on statins actually decrease their production of sex hormones themselves. In fact, there was a study that was done that showed that the people who are on statins that lower their cholesterol actually had a precipitous drop in their, both for men and women, their sex hormones, estrogen, progesterone as well as testosterone for men. So it's important to understand that there is a linkage between cholesterol. Cholesterol is not something that is, like vestigial to the body. Like, it is useful for all our for all our hormones, as well as a lot of the nerve cells, that coat with myelin, have to do with cholesterol. So when we, tank cholesterol levels to, a very low number, it's going to affect hormones. It's going to affect your brain function, your cognitive function, and it's really important to understand that there are negative effects of taking statins, which one day we'll get into a whole discussion about that, Dr. Ding.
That's an episode in itself.
Right.
I always feel that cholesterol, there, the good cholesterol, the reason, even when doctors waged a war on cholesterol,
Hmm.
we still figured out that there is like a good cholesterol that is supposed to do good for you. It is the carrier of your elements, and especially the fat soluble vital amines,
Hmm.
and many of these hormones, they're like carried by cholesterol. So there is good cholesterol, but there is also inflammatory cholesterol. Do you
Right.
recommend any particular supplements to your male clients about what kind of cholesterol to promote, and how does this tie with the fact some of your favorite peptides? Because your last episode with me also, we featured five of the your favorite peptides, and I one of the peptides was CJC ipimoral. And so how does that tie in with somebody's cholesterol and somebody's testosterone for
Okay.
anti-aging?
Well, it's a great question because of the fact that it actually all links back to that factor. For men and women, because of the fact that when their hormones have changed, they often start to become what's called insulin insensitive, which means that they start going through a metabolic process. But in testosterone specifically, what has been found is that men who are have low testosterone, and again, the clinical diagnosis of what that number is a little bit different than the way that I look at it, because I believe that, men who their cholesterol is below 500 or 550 have low testosterone, period. The range is somewhere between 200 and 900. And I explained this, yesterday. It takes the average patient, every average person at a certain age, and it increases, the number by two standard deviations up and two standard deviations down. So the patients who are, at a level of 350, which is not considered low T, actually feel very different than the patients who are at 800. But besides for that, it's been shown that people who have low testosterone actually have higher LDLs by the production of VLDLs, as well as they have an increase of triglycerides as well. So there's a direct linkage to patients who have low testosterone that actually have,
Can you stay there? Please stay there.
bad
Yeah.
cholesterol.
Yeah.
So the fact that replacing with hormones, like specifically for men, testosterone, it's actually going to improve their lipid profile, and that has been shown, that has been proven to be the case. So, like, it's a matter of, there's multiple other things that we can do to improve our metabolic state. I could talk about a couple of peptides we could talk about at the end, that will do this as well. But our major idea is that there is three major reasons why people are getting sicker and sicker in this country. And the three reasons is that they're hormone deficient is one. The second is the fact that they are insulin insensitive, which creates a general inflammation in the body. And the third is there is a energy deficiency in the body entirely. And so these three things, are the reasons why people are getting sicker, and all the major diseases, cardiovascular, stroke, cancer, all these things can be linked back to these three factors. And we'll talk about we'll talk about hormone deficiency today. We could talk about inflammation another day. I mean, there's so much research on these things, and now it's actually getting into the mainstream. But the problem is that a lot of the doctors who are treating patients see the data, see the research, but don't understand how to fix it. And we'll talk about how we can, help, our field, our medical field, to be able to do these things. So I think it's important that, like, just getting yourself, obviously exercise, eating right, but also hormone repletion is going to help you to actually decrease, your cholesterol levels. But again, there's a caveat to that. It's not always the case that, that the cholesterol levels are going to be, a completely negative effect on patients. There is a lot of evidence that, there has to be a natural balance, and this is one of them, because of the fact that the lower the cholesterol, the lower the hormones that you have in your body. And so that's a negative effect of that. So
So if
um,
somebody has, like, let's say low cholesterol, very low cholesterol, like they've had like cardiovascular disease and they are on super high statin, and
right,
now
right,
their LDL is like, let's say 70, for instance.
right,
So
yeah.
does that mean that automatically this person is going to be low in testosterone? And then when you replete this person's testosterone, for instance, you give them an injection, does it actually go to the end organ? Will it be able to be carried to the end organ, or is it going to just be like, because what is the delivery mechanism of this
So
hormone if it is not through cholesterol?
here's the thing I could tell you, that again, yeah, what you're saying is exactly right. There was a study that was done that showed that patients on statins, it, en masse, and this study was done in 2019, en masse, the patients who had, high levels of statins, all, you know, for the most part, there was a direct correlation to these patients. It wasn't a full, like, 100%, but like nothing's 100%, but there was a direct correlation to these patients had almost a 28 to 30% decrease in their hormone levels compared to, the placebo patients who were not on it. I mean, it was kind of a retrospective study. So, but the fact of the matter is that if you have low testosterone, what they found is that most of these patients are going to have what's called insulin insensitivity or insulin resistance. What that means is that the sugar that's coming into the body is not being processed correctly. And so what they found with these patients on that had low testosterone, they had increased insulin insensitivity. They had an increase of Alzheimer's disease by 63%. They had an increase in hypertension by 50%. They had an increase in cardiovascular disease by 56%. And they had an increase in blood clotting because of the fact that patients who have insulin insensitivity increase their von Willebrand factor, so platelets actually clot better, which is a negative thing, by almost 38%. So when you put all those pictures together, the patients who are low in T are insulin insensitive, which is leading them to have many of these things that we worry about as our patients, regardless of the fact that, the fact that, they're not eating right, whatever the other reasons are, the fact that they're producing all these problems because of the fact that the low T directly correlates to patients being insulin insensitive, which is just generally causing inflammation in the body. And there's a lot of reasons why. We can go into each specific reason why cardiovascular disease, why hypertension, why Alzheimer's disease all happen, because of this insulin insensitivity, which is directly correlated to low testosterone.
So guide me through this. Like, let's say I am a guy who is coming to you at, like, at the very brink of entering into my andropausal phase of life's journey.
Mhm.
So when I come in, and let's say I am not on any medications at this point, I
Right.
take some supplements, maybe like a vitamin A, DK, because my wife told me, and then maybe I do some protein shakes, and I am working out, and I'm very, however, I'm feeling that I am gaining weight and my cholesterol is bad. And now I've also developed a little bit of pre-diabetes.
Mhm.
It's getting harder for me to live my life the way it used to be, because I the same 2 cups of 2 shots of red wine with two glasses of red wine are now causing a headache for the next 2 days. So that's kind of like slight indications that things are not the same. So how would you start me? Would you start me with the GLP-1 to begin with, or are you gonna just are you gonna replenish my testosterone right away? Are you gonna do both? Or and I'm telling you that I'm feeling fatigued every now and then. So will you first fix my GLP-1 and my testosterone, or are you gonna just start me also on the CJC if I'm more or
So,
less?
so what I would say is, obviously, every patient is an individual, and we're talking about, each case being different. So I would say the first thing that you would have to consider is the person hormone deficient, and so you're going to look at the blood work. We're going to see where the testosterone levels are, and so if the testosterone levels are low, that means that they are hormone deficient, and that has to be addressed, because if it's not addressed, then everything else is, no matter what else you're doing, you're not going to get the maximum effect of what is the appropriate thing. If they're fatigued, if they're tired, like you're saying, they can't have that coffee, they can't have that coffee's not working for them anymore. A lot of those patients, they have an energy deficiency, which means that they're not producing enough ATP, which is ATP is, a fancy word for saying everything that, that the body uses. Every piece of energy, everything that we do is using ATP. And so if they're energy deficient, which many people are in general, um, they need something to boost that ATP production. And the first thing that I would say would be I'll put a lot of patients on NAD, because I
Mhm.
believe that NAD is kind of also foundational, to this problem. And then the third issue, like you said, they're feeling like they're gaining weight. They feel like they can't lose the weight. They feel kind of dragging. Yes, something like a GLP would be a great also start for them as well, because of the fact that what that's going to do is that's going to make them more insulin sensitive. So whether you use GLP-1, GLP-2, GLP-3, you want something that's going to help them become more insulin sensitive, hormone replenished, as well as replenished as well, as a foundation. Because without these products, you cannot go further with kind of like fixing anything else, because you're basically building a building without a foundation. You need to have the foundation appropriately right, and then once you're there, then you could start saying, yes, let's lean you out, let's get you build more muscle. And then I would go with something like either tesamorelin or CJC as far as growth hormone replacement. You can add other things if you're having any joint pains, things like that, like BPC. But on the foundation, hormones, energy, inflammation are all three things that are foundational, and GLPs, NAD, as well as hormone replacement are all the things that you need to set the foundation to start like replenishing for these patients, so that they can get their lives back and get their health back.
Yeah, perfect. Yeah, well, thank you. That kind of makes so much sense, because especially if that categorization that you have to fix the hormone, fix the source of lack of energy, and then also start the peptides for
Inflammation, yeah.
inflammation, and just pre-diabetic. Having high sugars is like it's a toxic state of being. And currently they have now so much evidence that not just alcohol that causes cancer cells, but also increased production of cancer cells is noticed when when you are running high sugars.
Right.
And then the thing is that GLPs, I've seen that they decrease the number of bad cholesterol cells because they remove the inflammation on the fat cells. So the cholesterol particles that are being released by the fat cells into the bloodstream just also gets improved. So I always I have been noticing for the past 3-4 years that anybody who is on GLPs, they're automatically there, even though they're not on these statins, their cholesterol just remarkably improves.
Yeah,
But yes,
absolutely.
we still have to do the hormones. So, what is a good dose that you would start somebody on testosterone? I mean, do you start them with once a month or like once a week, or is it age based, or is it um, just symptom based?
I mean, I think that for the most part, you have to look again at each individual patient. I mean, I think that weekly intramuscular injections are usually the protocol that I'll go with, as well as for men using estrogen blockers. And for females, they can take daily low doses of testosterone, and usually we'll do it transdermally, with a cream. But I wanted to just make a point. Like you actually brought up an interesting point, or like during the last discussion, you said something like, the fat produces cancer, and you're actually 100% right. And like we think about why women who are postmenopausal and supposedly not making hormones anymore are producing cancers that produce, estrogen sensitive cancers like breast cancer and endometrial cancer at higher rates than people who are that are premenopausal. And the reason is because of that estrogen is produced for both men and women by fat. And so you are still, so the more kind of, the more you are kind of having problems with your insulin sensitivity and just not, like getting to your lean muscle with, which for many reasons this occurs, you're actually producing all these cells that are estrogen producing cells that are unopposed by any other hormone because, like I said, progesterone itself is really not being produced by anything. And so you're producing cells, you're producing hormone from the fat that is actually going to be increasing the risk of breast cancer, endometrial cancer. So the reality is that women who are postmenopausal are more in danger of developing these cancers because of the fact that they're only really producing estrogen from their fat and some other from their adrenals as well. That's unopposed by any other sex hormones coming from the ovaries. So I thought that was an important point that I just wanted to like add to our discussion.
Yeah, no, that's thank you. That is like very insightful. However, I do sometimes feel that when women are placed, one of the things that I've noticed is that during menopause, it's not just the pause of your hormones that your ovaries are producing. It is like an all system pause that hits you, including your
Mhm.
immune system is pausing at that point. So one
Right.
of the things that I've noticed is that yes, and definitely cancers that arise from the estrogen positive, or like the cancer, breast cancer, or ovarian cancer, can definitely, the incidence is increased during postmenopausal years of existence. And I think that also has something very important to do with your cholesterol, progesterone, and estrogen axis,
Hmm.
and also testosterone, which is like very important for women. And we're like, I do not think that many of the women who think that they are on HRT are also on testosterone at this
Right.
point.
Yeah, I mean, there's definitely for women, testosterone is important for, just like men, lean muscle, which of course is going to decrease inflammation, make women stronger, and just, like help, like belly fat and all those types of things. But, and that's overall, we could see any type of visceral fat that's produced is going to actually decrease, increase the risk of a lot of these, like bad diseases like heart disease, strokes, hypertension, bad cholesterol profiles. But also, they also bone health as well for women is directly related to the testosterone levels, and with low testosterone levels, even adding estrogen, adding the calcium, adding the vitamin D, like all these things are being, again, there's no foundation for the one thing that really does help women more than, and men as well, more than anything, is having that testosterone levels present to be able to add to bone strength and bone health, as well as there's a sense of well-being with testosterone for both women and men, that kind of leads itself out to a feeling of, not, maybe not depression, but just feeling kind of I when I talk to my female patients, I tell them it's not, I wouldn't say it's depression, but I think that it's like a gray feeling. And I think testosterone has a big role to play for that, for both women and men. And I think that that's overlooked, like many other things, in hormone replacement, because of the fact that a lot of the practitioners that are practicing it, or the primary doctors, just don't have a great um, depth of experience with it, because it wasn't taught in our schools. And I think that it's kind of it's a real miss on our medical education, because I think that this is one of the biggest reasons why our overall health in this country has diminished greatly over the last 50 years, I would say.
100%. I agree over here also. Now I want to ask one question here, which is like, who is not a candidate for testosterone when you look at them, aside from the fact that if their levels are too high or whatever, but like, who is not a candidate? And how at like, at what point do you see, at what age uh, do you keep depositing testosterone in their system? And is there an age where, like, is it too late to start? How
Um,
late? How late is too late?
I have to, as far as like age goes, I don't think that, I mean, I have patients who are in their late 80s that still come to me, that, want to have the health benefits of testosterone and understand. And one of my oldest patients, he's almost 90. He was a pharmacist, so he understands this stuff very well. So the reason why he is not afraid of taking testosterone is because of the fact that he understands how valuable it is. I think that, for the most part, I tell patients that, look, I mean, you for for the fact that you have to inject yourself like weekly or every other week, with the fact that there is a cost involved, which is really not a huge cost, compared to the health cost that you have, from getting sick. I mean, you don't have to take, like hormone replacement for the rest of your life. It's, if you stop it, it's not going to, you're not going to have like a mal effect, other than the fact that you're going to lose the positive effects of hormone replacement. So I don't really think there's any age in particular that has to be stopped. I mean, patients who are active testicular cancer, or have a very strong risk of testicular cancer, then testosterone does have, like a strong feel with that. But going into the next, since we're on this topic, we'll talk about prostate cancer and testosterone, because this has a very interesting history, and I think that a lot of people are misinformed about this. And there are still doctors who are out there saying that testosterone is going to cause prostate cancer. Now, it is true that when patients are like post prostate cancer treatment, they do take them off testosterone and kind of castrate them in a way, like chemically castrate them. And the reason is that there is a level of what we call a saturation theory that, this, if you have no testosterone in your system, then the cancer cells can't grow more than, can't grow. But for most men, they do have some testosterone. But so the studies that were, I'll start with the original studies that kind of like linked testosterone to prostate cancer. In the 1940s, there were two men, both who were castrated, that had developed prostate cancer and kind of mets the bone. And this was the Higgins study. And so what they found is that these patients who they were given testosterone, they assumed that the testosterone was the cause of why these patients developed this metastatic prostate cancer. The reality is that these patients already had the cancer in the interim before they had received any replacement, and thus these studies were the whole impetus for these two gentlemen who ended up having the metastatic prostate cancer, and they falsely kind of linked it to testosterone. All of medicine, until the 2019 believed that prostate cancer was directly related to testosterone.
Based on
Until
these two people.
two people, yes, in 1940.
That's the largest case study.
Two people in
Two people study.
1940s. Right, and the problem was is that they were both castrated, and the one of the guys ended up with metastatic prostate cancer, and that was basically the impetus for all of medical education to say that prostate cancer is directly related to testosterone. Now, I talked about this about you with you,
Yeah.
Dr. Vin, yesterday, that a lot of times you have to step back and not look at everything as just a study. You have to look at reality, what reality is. And the reality is that who develops prostate cancer? Is it the 20-year-olds that have the highest testosterone, in their system, or is it the 70-year-olds, 67-year-olds that usually have relatively low testosterone? And the answer obviously is the 60 and 70-year-olds who have low testosterone, not the 20-year-olds who have the highest level of testosterone, in their system at that time. So that's just observational. You think about, like, how do I look at this? Okay, observational, the people who are doing this. So there was a urologist in Harvard. His name was Dr. Morgenthaler. And so Dr. Morgenthaler kind of looked at this study, and he said, well, look, he said, I'm a Harvard trained urologist. I was taught for years that, prostate cancer is directly related to testosterone. He had a group of men who said that they wanted testosterone replacement, although what about them that was problematic was that they had latent prostate cancer cells, which means they had cells that were dormant, but they were, concerning for developing prostate cancer. And so he made a deal with these people. And so what he said was, it was a few hundred people in the study. He said, I will give you testosterone replacement. However, you're going to need to come and get a biopsy, which, if you've ever had a testicular biopsy, I have not, but I know that they're very painful. He said that you will have to get a testicular biopsy at least every 1 to 2 months to make sure that there is no change in your prostate cancer cells. And the majority of them actually agreed. So this is how much they really wanted this, that they agreed to getting these hormone replacement, but also they're going to need to get biopsies. And in this study, actually, none of the people in the study actually developed prostate cancer or had even a progression of the disease. And secondly, many of them actually had a regression of the disease. So this study in itself, and this was in 2019, all of a sudden changed the entire kind of perception of how prostate cancer and testosterone are linked. And the reality is that, his findings, in the 2020s was that, if you have no testosterone at all, the cancer cells won't progress. But that's but there's only a small amount of testosterone that can possibly grow the tumors. But if you add more testosterone, and that's what the saturation theory is, that they reach a point where you could only only this much testosterone is going to make a difference, and then any more is not. So the patients already have testosterone in the system. And so adding more is not actually progressing the tumors. And this is how the study that he did makes sense to the fact that, adding testosterone replacement in these patients actually did nothing to progress their cancer. And the reality is that there's a lot of evidence that shows, and it's not, fully proven yet, but there's a lot of evidence that shows that men who are more estrogen dominant are more likely to produce prostate cancer than men who are testosterone dominant. And what I mean by that is that, like I said earlier, that the more less testosterone you have in your system, the more estrogen becomes a dominant force in your body. And so there's a lot of evidence that shows that men who are more estrogen dominant are the reason, which would make sense because, women who have more estrogen dominant produce more sex cancers like breast and endometrial cancer. And similarly, the studies are showing that men who are estrogen dominant are actually increasing their risk of prostate cancer. So I feel that, for the most part, in every person, you have to take, their history, their family history, all these things into account, strongly before you make recommendations. But as far as the overall health effects of testosterone, I believe that, they outweigh a lot of negative effects, negative potential effects, that possibly can occur in a lot of cases have been disproven, up to this point. So.
Wow.
Yeah.
No, that's great. So how one comment I have to make is that the levels of testosterone that are acceptable in men, we have some idea of that on that. But for women, do we have a sense of where you want the levels? Because for women, we didn't even try to figure this out, and it's like a thing that we're now testing out. So how do you
So
monitor that?
the ranges of testosterone in women, also they range from basically 0 to 90, 95, depending upon the lab. You know, um, their range, is closer to 30. Most of my patients, I'll keep them somewhere between 25, most of the women, 25 and 35. And this seems to be the right range for them. And anything below this, they should be replaced. I think they should be replaced. And I do replace them, with testosterone. As far as the negative effects with women, obviously the things that people hear about, the potential hair growth, deeper voice, things like that, Adam's apple growth. I mean, this occurs if you're taking mega dosing of testosterone. It doesn't occur, again, as long as you're replacing it to a level which is appropriate for the patient, and you know that by constantly testing them, constantly doing blood work to make sure that what you're doing is actually helping them and not potentially hurting them. And so as long as you stay in that range, all you're doing is you're adding back something that they're missing, that they had before and they don't have now. And as long as you do it in a responsible way, you're going to be doing, a great service to these patients because of, besides for obviously the health effects, it also has, positive effects as far as, vaginal lubrication, sexual desire, all these positive things that, that women, it's part of their quality of life. And that, regardless of what age, you're at, that you should enjoy all these things as well at any age, because it's part of the life experience. So I tell women that it is very important, that part of it as well. But it does have the positive effects of, decreasing, like cholesterol, increasing, the bone strength and lean muscle mass. So I think that it's very important for women. And I put most of my female patients on testosterone replacement, honestly.
So when you mentioned now a little bit ago that for because of this new study in 2019 about men, where they studied the prostate cancer in men and their use of testosterone. Is there any study for women, like if they have like so if prostate and testicular cancer, we correlate with women having, let's say, breast or ovarian cancer,
Mhm.
and if somebody is post that, would you still give them the testosterone and the hormone replacement therapy in women who have experienced this?
Yeah, I mean, I do think that, for women who are, post breast cancer, I have, I
Easy.
certainly have patients. As long as, I mean, as long as most of the studies that are shown in, breast and endometrial cancer is the, unopposed estrogen is the problem. So testosterone, progesterone, progesterone is one of the big, and I talked about this with you the last time. Progesterone is one of the biggest hormones that is the counter effect of estrogen, which is 100% necessary. And, again, I'm going to mention this because it drives me crazy every time I think about it. The OBGYNs who tell their patients that you don't have ovaries, you don't need progesterone, completely do not understand the hormonal, the hormones of women. And that is a sad testament to the fact that that is their life's career and specialty, that they do not understand the fact that progesterone is directly related to helping women not only with their sense of well-being, sleep, and their mental clarity, but it actually counteracts the potential effects of unopposed estrogen. So yeah, I think that that there hasn't been like a lot of like great studies for women in testosterone, but I think that there should be. I think that there I think that this is one of the things that, again, hormones, especially bioidentical hormones are kind of in the purview of not incredibly costly, not making pharmaceutical companies money. And again, the studies a lot of times are driven by who's benefiting from it as far as financially in a lot of ways, which is unfortunate because this is, our patients' health, and this is why we do the things that we do to try to kind of find the things that will help them and make their lives better.
So somebody like one of my clients who just recently had this battle with the ovarian cancer, and she used to be on HRT
Yeah.
previously. I have to find out if she's on testosterone. So now that she has overcome this, at
Mhm.
what point should we reintroduce the hormones into her system? And then somebody, for instance, if they're in their late 70s or 80s, and they have been they have not never started, for instance, hormones. What do we do? What is a good way to start? And would you consider
Well, I
giving
mean,
them?
I think with the the post cancerous patients, I think you have to really investigate what is the what is the impetus? Is there a certain hormonal trigger to the cancer in the first place? Before you kind of do that, as long as there's no trigger, I think that, again, the overall health of women and men are directly related to fixing their hormone deficiency. As far as patients who've never been on it, absolutely. I mean, these patients are being, are again being neglected as far as what is going to be helpful for them for their overall health. And I have no reservation. In fact, I find that I find it unfortunate for a lot of these people, and I'm happy to start them on hormones. Again, as a practitioner, you have to be the gatekeeper. You have to be the smart one in the room to be able to, because you're the one who kind of has to kind of manage how these hormones are going to work. And so I always, even with patients who have had certain types of hormones in the past, you'll start at a low level, initially, and then you kind of build up with it. And it's okay because of the fact that you just want you want to see how their bodies respond to it. You want to see how their bodies kind of metabolize the hormones, and you want to see how they uptake it. I have patients who, it took a lot for them to, even kind of recognize and uptake, for instance, testosterone. I had one patient who, for the longest time, I could not get her, testosterone level up to a reasonable range. And, we did all different types of, and sometimes it's the delivery method too. Some patients do better with sublingual, some patients do better with creams. So it really kind of depends on each individual patient, but you have to put the work in for the patient to be able to, it's not a set it and forget it type of practice. You really have to put a lot of extra time into it to really help each individual person.
Are there any foods that people can eat that promotes their testosterone production?
Yeah, I mean, I think for the most part, like what I'll say is that, a high protein, low carbohydrate diet is really kind of the best idea for, for guys. I mean, again, like I don't want to, like particularly say that this food is best, and because a lot of times they again, the best way to improve or increase your testosterone levels is to take testosterone. I say this probably 100 times in my office, on a daily basis. Like when patients will say, like, "Well, could I take this? I got to take that," and I'm like, "Well, I'm going to give you the tool that is going to fix your problem without actually doing anything else, and I know that it's going to fix it because I can." Know exactly how it's going to get into your body. I know how it's going to respond to your body. So I think that's important. But that being said, patients who are insulin insensitive, which means that they're essentially have metabolic syndrome. They have, like increased weight gain. They have increased, fat, decreased lean muscle. I think that it's important that a high protein diet is going to be kind of foundational to make sure that that's the more muscle you have in your system compared to your fat actually increases your testosterone levels. So I think that that in itself is important by exercise, and this is why exercise increases testosterone. This is how, certain foods that you're eating that are like more protein based increase your testosterone, because the reality is that lean muscle in itself is a testosterone booster, and it's probably the strongest testosterone booster you can have. I mean, there are some peptides that we talked about over time that actually produce testosterone or help like naturally produce testosterone for people who are, for instance, one of the things about testosterone is that when you take exogenous testosterone, it will decrease your sperm count. So if you're trying to, actively get pregnant, you're with a partner, one of the things I tell patients is that this is something that might not be right for you. However, what you can do for these patients is you can give them, certain types of hormones or peptides. HCG is one that mimics luteinizing hormones, and it helps produce testosterone naturally. Another peptide specifically is something called kisspeptin, and kisspeptin actually more directly affects the hypothalamus to produce luteinizing hormone, because it's actually a natural peptide that actually sits in the hypothalamus that actually does this. And so it's one of those things that will help produce more testosterone kind of more naturally without the negative effects of decreasing sperm count.
Wow.
Yeah.
Wow, Sam. Well, thank you so much, Dr. Frankel. We got a lot in
Yes, we
today
did.
for the, I hope it brings some clarity to our listeners. Let's meet again next.
Mhm.
The playbook series continues because my next question to you is about the growth hormone,
Yeah.
and at what point we go to those peptides.
So
And
like, so I'll give you one last take before
yeah,
we move on.
wrap.
So there is menopause, which
Yeah,
is the loss of female hormones. Andropause, which is
yeah.
the loss of male hormones, but there's also one other problem that no one talks about at all, which is somatopause. And that's actually the loss of growth hormone. And so I'll be glad to discuss that because that's something that no one talks about, which is actually a very big part of why people's metabolic systems are crashing down. So, yes, we will talk about that.
That is our next episode on somatopause.
Sure.
And, we know thy pause, what kind of pause your body is having. And to
Right.
identify it is the first step before we can remedy anything. So I am so grateful for your time. And hopefully, we'll be able to do this next week for the next episode after processing this episode.
Okay, great. Well, it was
Thank you.
great seeing you again, Dr. Den, and you guys have a great day, and we'll see you soon.
Thank you. Thank you so much.
All right,
Bye-bye.
well,
Bye. That was a fascinating conversation with Dr. Rob Frankel, and I hope it gave you a new perspective on how deeply hormones influence our health. From testosterone and metabolic health to insulin resistance and the role of cholesterol in hormone production, today's discussion reminds us that aging isn't just about getting older, it's about understanding the biology that drives vitality or decline. In our next episode of the Peptide Playbook, we'll go even deeper and explore something most people have never heard about: somatopause, the gradual loss of growth hormone, and how it shapes aging, metabolism, and longevity. If you enjoyed this episode, make sure to follow Bathroom Diaries, share it with someone curious about longevity medicine, and stay tuned for the next conversation. Until next time, this is Dr. Sophia Din reminding you that aging gracefully isn't accidental. It's something we can understand, influence, and actively design.